This next multiparametric MRI case of the prostate shows the value of multiparametric MRI to be added to the patient who is in active surveillance for low-volume, low-risk prostate cancers such as Gleason 3+3 prostate cancer. This patient is a 70-year-old male who was diagnosed with low-risk, low-volume Gleason score 3+3 prostate cancer, also called grade group 1, with transrectal ultrasound-guided biopsy. This patient was being followed with active surveillance. The problem is that the transrectal ultrasound-guided biopsy under Gleason scores the prostate cancer in up to 30 to 40% of cases. An MRI was obtained in this patient because the PSA was going up very rapidly and had recently reached a level of 6.0. So the clinician's concern was that the patient had higher Gleason score prostate cancer than had been previously detected with just the transrectal ultrasound-guided biopsy. So if we take a look at the axial T2-weighted images, and remembering that in the transition zone, the T2-weighted sequence is the king, you can see that there's this area of moderate, homogeneous T2 shortening within the transition zone that's non-circumscribed. So it has very, very fuzzy margins, okay? This measures over 1.5 centimeters in size. If we go to the corresponding high B-value diffusion-weighted sequence, we see that there's this area of very high signal intensity. This is the B-value 1400 image. And we see that it extends into the area of the anterior fibromuscular stroma. On the apparent diffusion coefficient images, the ADC images, we see that this corresponds with an area of significant restricted diffusion. This was well below a mean of 1,000 and with ADC values as low as 600. If we look at the corresponding dynamic contrast enhanced imaging, we see on the color overlay in this same area that there's an area of rapid washout and rapid plateau pattern of dynamic gadolinium contrast enhancement. So based on the T2-weighted sequence dominating within the transition zone, this is a PIRADS 5 lesion because it measures over 1.5 centimeters in size. We did not see any evidence of direct extraprostatic extension, seminal vesicle invasion, pelvic lymphadenopathy, or osseous metastatic disease within the pelvis, so that overall this suggested a clinical TNM stage of T2C. Based on the MRI findings, we did an MR-targeted biopsy in bore of this tumor suspicious region, and the biopsy came back Gleason score 3+4, or grade group 2, that's large volume. This completely alters the management of this patient. This goes from somebody that's being managed happily with active surveillance, thinking that they don't have clinically significant prostate cancer, to someone who has pattern 4 disease in their prostate cancer and needs definitive therapy. So this patient actually underwent a robotic-assisted radical prostatectomy as definitive therapy and was removed from the active surveillance management that they inappropriately had been undergoing prior to their MRI. Hello, I'm Dr. John Feller. I'm the Chief Medical Officer for Halo Diagnostics. And I'd like to talk to you a little bit about a new type of therapy called focal therapy for prostate cancer. The standard of care for detecting prostate cancer currently includes getting a screening serum PSA followed by a multiparametric MRI in patients with an elevated PSA, and in patients whose MRI is abnormal, then having an MR-targeted biopsy of the prostate. In a subset of men who have clinically significant prostate cancer confirmed with these standard of care detection techniques, they can go on to image-guided focal therapy. In our case, we do MRI-guided laser focal therapy. This is done under an IRB-approved clinical trial, so it's not yet considered the standard of care and is not reimbursed by insurance, but is being performed for investigational purposes. We at this point have 10 years of follow-up in almost 200 men. where in an outpatient setting, we've used MRI-guided laser focal therapy to safely and precisely treat prostate cancer that's intermediate risk and is confined to the prostate gland and hasn't spread anywhere else. Now you may ask yourself, well, what is the advantage of this MRI-guided laser focal therapy? The big advantage is that our cancer control is very, very similar to if the man had whole gland therapy, such as radiation therapy, or surgical removal of the prostate gland, which is called a radical prostatectomy. But the patients who have whole gland therapy are at significant risk of getting side effects. Up to 50% of them can get erectile dysfunction, and up to 25% of them can get urinary incontinence. In the 10 years that we've been following our patients that have had MRI-guided laser focal therapy, we have not seen any statistically significant erectile dysfunction or any significant urinary incontinence. So the bottom line is, with this new type of MRI-guided laser focal therapy, we can safely treat some forms of prostate cancer, have similar cancer control to if the patient had the prostate surgically removed or had radiation therapy, but at the same time we eliminate the side effects of whole gland therapy. No erectile dysfunction, no urinary incontinence.